discussion, which will be the crux of any free paper presentation. Okay, all the best to all of you.
So we will be starting with the first paper by Dr. Divya Kumar. Do we have Dr. Divya Kumar in the room? Okay. So moving on to the next presentation by Dr. Shanaya Kumar Gupta. She will be presenting on a case report on a very rare bilateral iridocorneal endothelial syndrome.
Good morning everyone. Today I am going to present a case report on bilateral iridocorneal endothelial syndrome. No financial interest. ICE syndrome involves an abnormal corneal endothelium that leads to varying degree of corneal edema, iris atrophy and secondary angle closure glaucoma. This syndrome typically affects young women unilateral with no family history. It comprises 3 clinical variants: Chandler syndrome, essential iris atrophy, Cogan-Rees syndrome. A 46-year-old male patient presented in OPD with diminution of vision in his both eyes since more than on slit lamp examination. Lid, adnexa and conjunctiva is within normal limit. Cornea is hazy. Anterior chamber Van Herrick's grade 2, correctopia, iris atrophy, synechiae and immature senile cataract grade 2 is present. In his left eye, best corrected visual acuity is 6/18. Should I stop? 6/18. Near vision is N6. IOP in his left eye is 16 mm of AG. On slit lamp examination, lid, adnexa and conjunctiva is normal limit. Hazy cornea, Van Herrick's grade 2, correctopia, pseudopolychoria, iris holes, iris atrophy and immature senile cataract of grade 3 is present. On gonioscopic angle closure is present in both eye. On fundus examination, right eye's cup and disc ratio is 0.5:1. NRR is healthy. In his left eye, cup and disc ratio is 0.8:1. NRR thin in superior and inferior quadrant. This is the OCT RNFL. Perimetry and specular examination was advised, but patient did not follow up. On the basis of above finding, we conclude that this is a provisional case of bilateral ICE syndrome of Chandler syndrome and essential iris atrophy. Differential diagnoses include posterior polymorphous corneal dystrophy, Axenfeld-Rieger syndrome, Fuchs endothelial dystrophy and aniridia. This case was managed by hypertonic saline drop for corneal edema, anti-glaucoma medication. Left eye cataract surgery with TAB with MMC is planned under guarded visual prognosis. The pathogenesis of ICE syndrome is unknown but appears to involve the abnormal cloning of endothelial cell which takes on the ultrasound characteristics of epithelial cell known as the ICE cells. Chandler syndrome is the most common type. Approx 50% cases of ICE syndrome is seen in Chandler syndrome. It is characterized by the abnormal corneal endothelium, resembles hammered silver. The second one is the progressive iris atrophy. This one is characterized by the iris atrophy in early stages, correctopia, pseudopolychoria and peripheral anterior synechiae. The third one is iris nevus syndrome, that is also known as Cogan-Rees syndrome. It diffuse nevus that covers the anterior iris surface. Correctopia and iris atrophy is usually absent in 50% of cases. Prevalence of ICE syndrome is less than 1 per 2 lakh population, in which glaucoma is present in approx half of all cases. Viral infection with herpes simplex virus or Epstein-Barr virus led to low-grade inflammation at the level of corneal endothelium that result in the unusual epithelial-like activity. Clinically, the corneal endothelium that has been described to have a hammered silver or beaten bronze appearance in ICE syndrome patients, similar to the corneal guttate seen in the Fuchs endothelial dystrophy. Corneal endothelial cells are pathognomic for the ICE syndrome and be referred as ICE cell when seen on the specular photographs. Trabeculectomy is the surgery of choice for ICE syndrome. Yanov reported 64% cases success rate 1 year post-op and 36% at 3 years when the trabeculectomy proves to be ineffective. The reason being usually is excessive subconjunctival scarring. Long-term surgical outcome reported to be slightly better with the glaucoma drainage device versus trabeculectomy with antifibrinolytic agent. Conclusion, ICE syndrome is usually present in unilateral and young age women, but this present in the middle aged man bilaterally. That's why. Thank you.
Thank you. What percentage of eye syndromes do you know will be bilateral?
Ma'am,
How would you differentiate this from an anterior segment developmental anomaly?
on the basis of
I would say it's a differentials of an ASDA. Okay. Thank you.
Do we have Dr. Bichishmita Jaina here in this room? Okay. So next we have Dr. Vidya Bhushan Kumar, and he will be presenting on sutureless limbo-conjunctival autograft after simple excision of limbal dermoid.
This? Okay. Yes. वीडियो चल जाएगा ना? कीजिए. Good morning, ma'am and sir. My topic is sutureless lamellar corneal graft in limbo-conjunctival autograft after simple incision of limbal dermoid. I have no financial interest. A limbal dermoid is a congenital solid benign tumor which comprises tissue of ectodermal and mesodermal origin. Removal of the limbal dermoid is not only performed to improve the cosmetic appearance of the eye, but more importantly to prevent the loss of visual acuity caused by the corneal astigmatism. There are various techniques to remove the limbal dermoid, including bare excision, amniotic membrane transplantation, lambda and penetrating keratoplasty. Major risk factors are intraoperative perforation, postoperative epithelial defect, and peripheral vascularization of the cornea. I am presenting this case is we report a surgical technique for the existing pediatric corneal limbal dermoid and sutureless lamellar corneal graft up in 2 patients. On post-operative follow-up, we got visual acuity 6/6 and there was no sign of rejection seen. This technique offers improved long-term stable ocular surface and cosmesis. Case 1 is 6 years old boy presented with the us with the right eye inferotemporal limbal dermoid of size 5 into 5 millimeter with base, corrected visual acuity was 612 with +1 diopter sphere and -4 diopter cylinder. Anterior segment OCT done, and we find out that this shows predominantly corneal involvement. Under general anesthesia, conjunctival peritomy done at limbal and base of the dermoid is identified and separated from the crescent blade meticulously. Surgical site make dry and clean. After applying the glue partial thickness donor cornea is placed on conjunctivized repositions. So this is pre-op post picture and the post-op day 1 picture. Case 2 is a 5 years old female presented with the right inferotemporal limbal dermoid of size 4 to 5 into 6 millimeter. Base corrected visual acuity was 6/18 with -1.5 diopter sphere and -2 diopter cylinder at 160 degree. This is the same surgical technique applied, and this is the pre-op picture, and this is the post-op day 1 picture, ASOCT post-op picture, which is also showing good cosmesis and maintaining of the corneal thickness. Post-operative at 1 week and post-operative at 1 month. So post-operative, since the same surgical approach applied in both patient, outcome was and visual in the form of cosmesis and vision was excellent. Both patient had base corrected visual acuity was 6/6. First patient had -0.5 diopter cylinder at 10 degree, and second patient had no significant refractive error. The method of choice is to treat the limbal dermoid is surgical excision, and purpose of yearly excision to prevent amblyopia. The main sequelae of this operative were remaining corneal opacity and the pseudoteresium, conjunctivalization of the cornea, and limbal cell deficiency. Stem cell transplantation to use use of mitomycin C may be the more beneficial approach. The purpose of use of partial thickness corneal graft in amniotic membrane transplantation is primarily to achieve the volumetric filling of the stoma and the epithelial defect after the removal of the limbal dermoid. They also anticipate the reducing the scarring due to the faster epithelialization. This may show advantage in the term of shortening of the operating time because of conjunctival sutures could be skipped, and the aid of the fibrin glue, the need of the suture removal and the foreign body sensation from the conjunctival sutures could not be avoided. Which could be helpful as the surgical option in the for child with the congenital limbal dermoids. Take-home message is sutureless limbal dermoid corneal graft after simple excision of limbal dermoid with use of the fibrin glue can be good choice for the treatment of the patient are selected appropriately. Video. It's not
There
right.
was some problem with running the video. Can you just...
Back कीजिए. Back.
Yes, sir. Bas.
So, this is the technique. After conjunctival peritomy and fast forward, yes, separation of the dermoid from the base by the crescent blade meticulously done, and then after complete removal, just making the dry of the base, and then we applied the glued. And partial thickness lamellar graft was applied and with glue and thank you.
That was a wonderful presentation, Doctor. That was a wonderful presentation, I should say. Ma'am, over to you.
How would you tailor the thickness of your graft?
Ma'am, depends upon the depth of that. On the basis of ASOCT, we have to see preoperatively how much corneal involvement is there. That we have to see, and then intraoperative we have to see that the deficiency depth of the deficiency is there. Accordingly, we have to tell her, ma'am.
Intraoperatively, how do you assess the thickness of your graft? How do you, if you want 100 or
200 macron.
You use a 200 standard for
Yes,
that's
yes, sir.
How do you, so you use 200 micron graft?
Yes, sir, almost.
And how did you get that 200 micron graft?
That's why I told you partial thickness we are taking. So we considering that at least 500 macron is there. So we have to take half or less than half of the thickness,
Okay,
and
so
depend on the depth of gap is there.
Yeah, so what happens is usually when we do a limbal dermoid, we dissect and usually we don't know what depth we are going. So sometimes it could be 300, it could be 400 also. That's
Yes,
why
sir.
the reason why you put a corneal graft, because it becomes deep after dissection. To fill that depth, you want to put a corneal
Yes, sir.
graft.
Yes, sir.
Yeah. I have just one thing with you. You have written the free paper title is Sutureless Limbo-Conjunctival Autograft.
Yes, sir.
But you have put a lamellar corneal graft, right?
With lamellar corneal, but topic was not taking full. That word should be limited. So in topic we have
Okay.
to put limited words, sir. So
Okay.
that full topic was there as well.
Nice presentation with you.
Thank you,
Good.
sir. Thank you.
Next in the line, we have Dr. Astha Agrawal. Is she here in the room? No. So, to the next presentation by Dr. Pallavi Sinha, again absent, and then moving on to Dr. Rajneesh Sin. Right. Next, Dr. Rakhi Kushumis, and she will be presenting.
Good morning everyone. I am here to present outcome and course of Tieren's patch graft and corneal perforation and desmetocele. I have no conflict of interest to declare. So corneal perforation and desmetoceles are potentially sight-threatening conditions caused by a variety of ocular disorders, and if not treated timely, it can lead to several complications. Therefore, corneal integrity must be restored promptly to prevent complications and vision loss. There are several methods described in the literature. However, they have their own limitations and availability problems. So there has been a growing interest in use of Tenon's patch graft because of its major advantage of being immediate and all the time availability. So this paper was done to assess the efficacy and clinical outcome of TPG in corneal perforation and desmatoseals, and also to identify the possible predictors of successful outcome. So this was a study done from 2018 to 2021 in 85 eyes of 83 patients who underwent TPG. Written consent and approval from IC were obtained. Parameters that were noted to assess the outcome were size of corneal lesions, underlying etiologies, time to epithelialization and scar formation, BCVA, and course and outcome of TPG. So all surgeries they were done under peribulbar anesthesia, and first of all we removed the debris, and Tenon's tissue was then harvested from superior nasal quadrant and placed on the perforation and desmatocele sides, covering all the edges and secured with glue and with Tenno monofilament as an overlay suture or as an interrupted suture. In post-operative treatment, topical antibiotics were given to all patients, and depending upon the underlying etiology, the treatments were prescribed. Follow-up was at least 6 months for all the patient. Outcome measures, formation of leukomatous corneal scar and adrenalinleucoma was considered with well-formed or partially formed AC was considered as a successful treatment at the end of 3 months. And if there is a corneal scar with flat AC, graft dehiscence, graft ectasia, need of therapeutic PK at any point of time or evisceration, then it was considered as a treatment failure. Results: average age was 49.3 and mean period of follow-up was 9.2 to 36 months, and majority of the cases were done in the COVID pandemic period when eye banking system was adversely affected. And 68% cases were perforation and 32% were desmatoseals, and the most common underlying etiology was infective keratitis in 48% cases, and out of which viral etiology was more common, and autoimmune disorders in which rheumatoid arthritis was common. Mean size of perforation in both the groups was 4 millimeter around, and 70% of successful cases required subsequent keratoplasty for visual rehabilitation. So our outcome was 87% cases had successful outcome, while 13% cases had failed graft, out of which 12% belonged to corneal perforation group. Median time for complete epithelialization was 3 weeks, and median time for duration of scar formation was 15 weeks. Most common complication or consequence we encountered was corneal neovascularization in all the patients, which disappeared after performing PK. And other than that, graft dehiscence, graft displacement, ectasia in one patient, and flat AC in 3 patients. We did a logistic regression analysis and found that desmatocele, non-infective etiologies, viral keratitis over other infectious etiology, and paracentral or peripheral lesions performed very well. So consequence of Tenon's patch graft, here we can see the vascularized scar, adrenalinleucoma, and translucent scar at the end of 3 years. We performed double layered TPG in elderly patients, graft melt or graft infection in post-operative period, and here we can see the course of Tenon's patch graft in a case of desmatocele. At the end of 1 week, the graft was edematous without any epithelialization, but at 3 weeks, the graft became completely epithelialized with compact in nature and hyperechoic, and at 12 weeks, here you can see the new collagen deposition under the graft. So Tenon's capsule is a dense, elastic, vascular, fibrous connective tissue, and we use anterior part because of it is rich in fibrous tissue and a smooth muscle fiber. And overall success rate in our study 87%, and previous study also shows a percentage from 74 to 90%. And since the Tenon's graft is an opaque tissue, it always require some keratoplasty in if we are putting graft in the center. So conclusion, TPG may be considered as an effective or inexpensive treatment to restore structural integrity in perforation and desmatoseals, particularly when we don't have donor tissues available to us. And AIOCMTC found to be a valuable tool, non-invasive tool for the monitoring of the status of TPG. Thank you so much.
That was a very nice presentation, Dr. Rakhi. Very nice.
Thank you, Rakhi. I think that's a good presentation. What do you see as a prognosis if you have to take these cases for keratoplasty subsequently?
We performed 4 cases. Optical PK was performed in 4 post-TPG cases, and we found that there was no problem because we found AC was either well formed or partially formed without any synechia. And after in the post-operative period, we found that all the vessels which actually appeared in the course of TPG, they disappeared after some period of time, and outcome is really good. We performed around 4 cases for optical PK, and they are doing nice.
So how much time does it take for the vascularization to go away after
It took around 4 to 6 weeks. I would say within 2 months, all the vessels disappeared.
Nice presentation, Dr. Aki. Just one question. Why did you see vascularization in majority of the cases, like 85%, 83% vascularization?
I cannot make out the cause exactly, but in all the tenons, at least one vessel, and that vessel actually vascularized the graft. All the cases in follow-up, they have vascularized, nice vascularized, small graft, compact graft was there, except in few cases like in SJS or in cases of rheumatoid arthritis, I didn't find these bigger vessels, but in cases of microbial keratitis, particularly viral etiology, they all have that big vessels growing around the tenons patch graft.
Yeah, probably because 50% of the cases, 45% of the cases of viral etiology.
Yes.
Probably that could be a reason. Good presentation,
Yeah.
nice.
Thank you.
So next in the sequence we have Dr. Khushbu. Please, he will be presenting on conjunctival impression cytology in eyes post-LASIK.
Good morning everyone, myself Dr. Khushbu Lalhare, junior resident from MGMS Sevagram. Today I am here to present a paper on conjunctival impression cytology in eyes post-LASIK. Conjunctival impression cytology is a useful investigating tool for analyzing ocular surface disease. It is non-invasive and reliable information about the area sampled with the minimal discomfort to the patient in eyes undergone LASIK. Abnormal cytology and significant change in the conjunctival cytology have been observed with the help of impression cytology. It was a hospital-based prospective observational study done in the refractive clinic department of the ophthalmology in a tertiary rural care hospital, and 10 patients undergoing LASIK surgery between the age group 20 to 40 years having stable refraction since 1 year. Then the study procedure, the written informed consent was obtained from all patients. 10 patients undergo detailed ophthalmic examination using torchlight and slit lamp for anterior segment evaluation. Conjunctival impression cytology was done pre-LASIK using millipore filter paper 0.45 micron from the bulbar in inforotemporal conjunctiva adjacent to the limbus. Then slides were fixed in the freshly prepared solution containing 3 parts acetone 100% and 1 part methyl alcohol and ethyl alcohol for 4 to 6 hours. After fixation, staining was done with PAP, that is papaniculi, and the periodic acid skeef reagent, and grading was done accordingly. The conjunctival impression cytology was again repeated 4 to 6 weeks and 12 to 14 weeks after LASIK. The goblet cell density was calculated by calculating the average number of goblet cells per 100 epithelial cells, and the following grading system were used. Grade 1 is more than 30 goblet cells per 4 high power field. Grade 2, 15 to 30 goblet cells per 4 high power field. Grade 3 is 5 to 15 goblet cells per 4 high power field, and grade 4 is less than 5 goblet cells per 4 high power field. Cellular cytological grading was done by using Seni et al. Criteria. Grade 1 was small round epithelial cells with nucleus cytoplasmic ratio 1:2. Grade 2, good cell sheet consisting of larger polygonal epithelial cells with a decreased nucleocytoplasmic ratio of 1:3. And grade 3 is larger polygonal cells with further decrease in nucleocytoplasmic ratio. And grade 4 is larger polygonal cells with pycnotic nuclei. The result, the 10 participants, including 7 male and 3 females, were enrolled in the study, and the results were calculated using Friedman test as the data were non-continuous. All the 8 tables showed p-value more than 0.05, which was insignificant. These are the slides which we have obtained in the LASIK patient. First one is the squamous metaplasia grade 1. Second is the squamous metaplasia grade 2. Third one is the squamous metaplasia grade 3. Fourth one is goblet cell density grade 1. Fifth one is goblet cell density grade 2. And sixth one is goblet cell density grade 3. The purpose of the present study was to determine whether there is a reduced conjunctival goblet cells and squamous metaplasia in the patient after refractive surgery. Study by Moore et al. Showed goblet cells can tolerate up to a threshold of ocular surface disruption, as shown by clinical examination before they exhibit changes. Study by Ryan et al. Observed conjunctival goblet cell density tended to decrease in the early post-operative period after refractive surgery. And study by Lee et al. Found that the goblet cell decreased substantially by 1 month post-operatively, and conjunctival squamous metaplasia increased significantly by 2 months post-operatively. My conclusion was there were no significant change in the squamous metaplasia and goblet cell density in the patients at 4 to 6 weeks and 12 to 14 weeks post-LASIK. Thank you.
Well presented, Dr. Vishwa.
Nice presentation. I think the number of cases were very less to come to any conclusion in this case. I mean, 10 patients, and because all the authors have concluded a different opposite to what you have concluded.
Yeah.
So I think that's a major flaw of the case. Thank you. Thanks.
Okay, thank you, sir.
Okay, next we have Dr. Amrita Pradhan. Dr. Amrita Pradhan, are you here in the room? Okay. Ma'am, do we have anyone else to present? Okay. Ma'am, we have Dr. Divya who was supposed to present first. Yeah, please, Dr. Divya. She will be talking about restoring ocular integrity of perforated corneal ulcer using host tissue derived from keratoplasty.
Very good morning to everyone. Myself, Dr. Divya Kumari, and I will be presenting my topic, restoring ocular integrity of perforated corneal ulcer using host tissues derived from keratoplasty. Aim of the study was to report initial clinical outcomes of therapeutic PK of perforated corneal ulcer using host corneal button. The therapeutic penetrating keratoplasty is a surgical procedure to restore global integrity or to resolve infectious or inflammatory keratitis unresponsive to medical treatment. COVID-19 pandemic caused unprecedented crisis to corneal surgeons. There was acute imbalance of demand and supply of tissues. We report 2 cases that required therapeutic PK and were managed successfully by graft derived from host tissues of patients undergoing optical PK for PBK. Case 1, she was a 28-year-old female, history of trauma with wooden stick for 6 days duration. She had a complaint of redness, discharge and decreasing vision in right eye and was previously treated with eye ointment itraconazole, eye drop moxifloxacin, eye drop tobramycin and eye ointment atropine with no symptomatic relief. Systemically, she was within normal limit. On ocular examination, we could see visual acuity was hand movement close to face with PR accurate in all quadrants, and in cornea, we could see perforated corneal ulcer of greatest diameter of 5.1 into 4.2 mm with 0.5 mm diffuse stromal infiltrate in surrounding corneal stroma. Fundus examination was done with the help of B-scan ultrasonography, and it was found to be normal. Preoperative investigations were normal, and KOH wet mount showed filamentous septate fungi, and SDA showed Aspergillus species. Management was started, and patient was put on eye drop 5% natamycin 1 hourly and eye drop homatropine 2% 4 times a day and eye drop moxifloxacin 6 times a day, and tablet ketoconazole was started 200 mg twice BD. And further therapeutic PK with intracameral injection of voriconazole was performed using glycerine preserved non-vascularized host graft obtained from optical PK of PBK patient. Size of graft was 7.5 mm. On post-operative day 1, graft clarity was 0. Graft-host junction was well opposed, anterior chamber was formed, and patient was maintained on same medications as pre-operatively. Patient was followed up weekly for the next month. Graft clarity didn't improve, but there was no recurrence of infection. Follow-up through telemedicine services was done. At 1 year, graft was completely opaque with inferior conjunctivalization. Anterior segment OCT was done with topcon DRI OCT Triton. Optical PK was performed after 1 year. The final visual acuity at 1 month post-operative visit was 636 parts with a phakic correction. Histopathological examination showed stratified squamous non-keratinized 5-layer epithelium. These are the pictures. In February 2022, this is a case 2, 68-year-old female presented with complaints of redness, pain, photophobia and decreased vision in left eye for duration of 1 month. Vision in left eye was PL positive with PR accurate, and we could see left eye had perforated corneal ulcer of size 4.7 into 4.5 mm with Descemet's membrane folds and shallow anterior chamber. Rest of the examination were within normal limit. KOH wet mount showed filamentous septate fungi and SDA showed Aspergillus species. Systemic examination was within normal limit. Treatment was started same as the first case, and therapeutic PK with intracameral injection of voriconazole was done, and with non-vascularized host tissue obtained from optical PK of PBK patient. The graft size was same. Post-operative day 1 graft clarity was 1+, and graft host junction was well opposed. Anterior chamber was formed. No exudate or hypopion was noted. Follow-up was done weekly for 3 weeks. First 3 weeks, and no recurrence of infection was noted. Graft was well epithelialized at the end of 1 week due to widespread pandemic. He was followed up by telemedicine services. At 1 year, follow-up visual acuity in left eye was perception of light with projection of rays accurate in all quadrants. Graft clarity was 0 with devascularization as 4 and 5. These are the pictures. During lockdown, the number of donor corneas collected and thus emergency therapeutic PK performed decreased significantly. Tissues from other eye banks also could not be transported. People started using glycerol preserved corneas or scleral patch graft for therapeutic purpose. We anticipated tissue scarcity due to COVID-19 pandemic and promptly preserved 4 host tissues derived from optical PK and glycerol. Tissue were utilized on day 6 and day 8 of their storage respectively. Because even glycerol preserved corneas were not available, therapeutic take-home message is therapeutic PK using host tissue obtained from the recipients of optical PK are safe and effective option to restore ocular integrity in cases of emergency during shortage of fresh or glycerol preserved corneas. Optical PK is required for visual rehabilitation later. Thank you.
Thank you, Dr. Divya, and that's a good presentation.
Yeah, good presentation, Divya. Did you do the serological test for these host tissues?
Yes, ma'am. Actually, these host tissues were obtained from optical PK patients who were already before surgery. We do serological test in all those patients. So during optical,
do serological test for all your optical keratoplasty patients?
All patients, irrespective of any case, we do serological test.
It's a very good idea to use host tissue, obviously during the COVID time, but I have 2 reservations with this. One is the PBK could be because of any reason, sometimes CMV or sometimes HSV can lead to corneal decompensation, and that can have a recurrence in the patient who's undergoing transplantation. That is one thing. The other thing is the size of the graft. Usually PBK we take 7.5, and for therapeutic usually the size which you showed was almost was looking like 5, 6, 7. So you would want a large graft so that no recurrence, although there was no recurrence in any of the case. But always keep in mind, I think PBK etiology could be anything. It may not be just a corneal decompensation, age related, or following a cataract surgery.
Okay, sir.
That could lead to recurrence of disease in the patient who's undergoing transplantation. Otherwise, it's a good idea. Thank you. Good presentation.
Thank you, everyone. Thank you, judges. And with this, we have come to the end of this session. Thank you all.